So I will be talking about a needs assessment and feasibility study for a safer drug consumption facility in Edinburgh, which I led, but it was a big team and an amazing team of people who did some great work on it. So I'm not going to take any credit for most of the content. I'm just kind of steered the ship a little bit. Just out of interest, kind of prior to re-entering academia, I was for a few years the Chief Executive Officer of Transform Drug Policy Foundation. So I've got a kind of an advocacy experience on this and now a kind of research, which is quite interesting to see for those two things to have kind of collided somewhat here. So it's an interesting, been an interesting experience for me. Oh yeah, there you go. Again. So this is the study. As you can see, there's a number of people on the team who I'll talk about as we go through. Just to give you some background to it, though, the study was requested by the Policy and Sustainability Committee of the Council, I think back in 2022 originally. And then it was commissioned and launched. We started it in 2023, February 2023. It was quite a short process, it was very intense. We actually managed to get quite a lot done, I think, in the time allocated. It was completed in November 2023 and then published in February 2024. So if you want to see it, it's on the website, the council website, but it's kind of buried away. So I can share a link somehow for you to get to it. It's not the easiest thing to get to. And then it's debated by the Policy and Sustainability Committee last week, and they passed a motion to move the process forward, to instruct the ADP to speak to the Scottish Government about funding and to develop more of an action plan around this. It was also there was a linked report on drug checking services, which I'm not going to talk about here, but that was also debated, and there was also support for further action on that. Part of the reason I put the dates in there is on the day that it was launched, there was a bit of a kind of hoo-ha in the press about, oh, this has been sat on by people and it's been suppressed and all that kind of thing. And it wasn't. It was just, this was the timeline. The timeline was a bit shorter than I think people thought it was going to be. But when I was at Transform, we accused Bristol City Council of sitting on a similar report, so that was calm sitting on. Okay, so what did the research involve? Well, there were kind of four parts to the research. One part, which was led by Danilo Falzon at Stirling, was a global review of the evidence. Now, there's lots of reviews of the evidence out there, and Gillian Shorter's led a brilliant review of the evidence, which came out recently. What this focused on was we had a particular interest in service design and evaluation. I'll come back to that later. We were particularly concerned not so much about the high-level evidence around what we know that safer consumption facilities can do, but it was more about what different design models there are and what different service models there are and what are the kind of core and ancillary elements of that. We really wanted to look into that. Just briefly, I'm calling them safer drug consumption facilities. When I was at Transform, we called them overdose prevention centres. I recognise there's a challenge around the language here, and I think from an advocacy perspective and from a research perspective and from a policy perspective, the different names are, they suggest different things, and that's important. But safer drug consumption facilities is the kind of language that's being used now in Scottish Government, so that's what I'm going with. So we did that. Then there was a quantitative analysis of routine data on a range of, or administrative data on a range of indicators, which was led by Wendy Masterton, looking at key areas of harm in the city, which I'll come back to talk a bit about that. So that's kind of quantitative element. Then there was interviews with people with lived and living experience and families, which was led by Josh and Sam back there, who did some brilliant work with people. Most people with lived and living experience, but all the work were recruited at the Simon community in Clare's here, so they were great and really, really helpful in facilitating that. And we got some really, really rich insights into what potential service people using the service might want and might need, and what their aspirations and anxieties were as well, which was really interesting. I'll come back to. And then we had a series of interviews with professional stakeholders, decision makers that Andy Perkins, Figure 8, led, which was we were trying to get a sense then of what the people who are in the system who might be responsible for commissioning or delivering parts of this, what they thought was needed, but also what they thought was possible, and I'll come back to some of the findings around that. So it was a pretty thorough report. It ended up being 97 pages long, which when I'm teaching my students about writing policy briefs for local authorities, well, don't make it too long. We made it 97 pages too long. It does have an executive summary though, so it's there. So what were some of the key findings? I'm just going to go through this, and it's a bit dry, but I'm just going to present the key findings really. we found that there were significant drug-related harms in the city that could be mitigated by a safer drug consumption facility. It's a bit of a dry way of putting it, but we wanted to make that clear, that because we actually went into the process on principle with the view that we were going to take a neutral view at the start as to whether a facility was the right thing or not. We didn't want to go in already decided as to what the outcome was going to be. We thought actually on principle we shouldn't do that, so we approached it cautiously and kind of conservatively in that sense. A really important finding was that drug use and harms were dispersed across the city, so there wasn't like an obvious area where you would say this is definitely where a facility should go, but there were hotspots, and I'll come back to that in a little while. But that is a challenge, and it's a challenge that I will come back to, and I think it's a challenge probably for any facility. It is about location and distance of travel. Especially from the quantitative work, high levels of cocaine injection, come back to the point Matt was making before, and high levels of benzo use as well. I'll come back to this. This has really kind of serious implications, I think, about how we think about safer drug consumption facilities and design and training and all that kind of stuff, which I'd be interested to have a conversation about, so hopefully we'll have time for that. Very strong support, as you may expect, amongst people with lived and living experience, amongst families, also amongst professional stakeholders, but I will come back to that as well, because prioritisation was a concern. So it wasn't that people didn't support facilities, it was like, if you support it, but then this is the opportunity cost, how much do you support it now? And that's the question that is really challenging, I think. Other kind of findings was, okay, so what did the people living in the experience say was most important about a facility? Well, actually, interestingly, I guess maybe it was almost taken for granted that intervening in overdoses was what it was going to do. But the thing that people really talked about was the provision of compassionate spaces. Community creation, there's a lot about community creation, there's a lot about how people felt about their relationship with the wider community when they were having to take drugs in public. And the concern for the community around that was very interesting. But also a sense that this was an opportunity to develop supportive communities. Integration with wider services was seen as a really key benefit. One of the ways we can think about this, I've been thinking about this, is in some respects, there is a kind of safe haven element to a facility. In some ways, there's a gateway element to the facility, and those were both important. There was strong support for peer delivery, kind of informality, accessibility. I think that was no surprise that came through, and a kind of scepticism about a highly kind of medicalised model. But there were also concerns, anxieties about operating procedures and safety and security and safeguarding. There was, people saying, how are you going to keep everyone safe here? Because it could be a bit of a tricky environment. And that came out a lot. And so I think that's something that was really worth thinking about. As I say, links between services and wider support all seems really, really important. We can maybe come back to that about the extent to which that is a justification for a facility, or to the extent that seems just an additional benefit of a facility. And as I said, professional stakeholders very supportive, but aware of opportunity costs and competing priorities. So going back to that point about locations, as I said, there was no... Getting the data was really difficult in terms of identifying locations. We didn't have much granular data. A lot of it was at postcode level or ward level or health service area level, which was just too big to really be meaningful. The two things that we had at kind of data zone level, which is a very small, like about between 500 and 1,000 population level, was non-fatal overdose call-outs for ambulances. We had that data, which was great, really useful. And we had drug-related death data as well. And what that showed, I'm not going to go into detail here, but what that showed, generally speaking, as I said, it was dispersed across the city. But there were hotspots in the Old Town and around Great Junction Street, parts of Leith. Again, probably no surprise there. The question then becomes, how do you balance the pragmatism of a more central location against what that means for people in more dispersed locations? And therefore, is a single location what you're looking for, or are you looking for multiple lower threshold and less formalised locations, or embedded in existing services across the city? So, this is just the same stuff. The thing of like talking before you've gone to the slide, but there you go. Yes, we had lots of conversation about pragmatic travel distances, and this is another thing I'd be interested to hear people's views on that. It's a challenge to say, what distance will someone travel to use a facility, and how does that differ by what they're planning to, what they're going to be using in the facility as well? Because with stimulant use, that's probably going to be different again. So it's a real challenge, and I think it's one that needs to be thought through. Do you go for pragmatic central location? Do you embed existing services? Do you focus a bit more? I'm just trying to clarify this just now around kind of high tolerance, not as an alternative, but as another model in existing services where you can reduce a lot of harm that way, and it can be much more dispersed and much easier to access. Mobile provision wasn't seen as practical for various reasons. There were cost issues around and there were access issues. So interestingly, that didn't come out as one that was particularly practical in this case. So implications in terms of service design, as I said, peer delivery and accessibility was seen as really, really important. So that's I think that's a very significant thing. Then this point again about stimulant injecting, cocaine injecting. What are the design and training implications? And I think one of the kind of challenges about this has been that not all of it, as Matt will know, but a lot of the kind of literature and thinking around safe consumption facilities has been very much based around an opiate model. And I think that's still the case now. And we were very keen to say we've got to think about this as a different set of challenges. And it was slightly frustrating to say when it got debated at council last week. It was as if none of that had been like that. Had kind of, I think people find it quite difficult to pivot towards that and to orient themselves towards those questions. Same with benzos as well. A lot of the people we were speaking to, a lot of people Josh and Sam were speaking to, were saying, look, there's also challenges there around if people are taking benzos and how what their response is going to be. The kind of timelines of someone who's taking cocaine, someone who's taking benzos, someone who's taking heroin are different. And how do you manage that when you've got a limited space and you don't know what to do with the bits of space you have? So I think all that's really important to think about. As I said, safety, oversight and operating procedures. Obviously, operating procedures are really important in terms of keeping within the law, and they create all sorts of challenges around, again, we just spoke forward, someone picking up drugs and all that kind of stuff. But there are difficult challenges around how you make something informal and accessible and safe, and how you do that in a way that works. Integration of local services, already mentioned. And then one of the things we did in the study was we did a table of what we saw as being kind of core and ancillary provision that you could get that the global literature tells us different facilities have. And there's a question there around, okay, well, given financial envelopes, as it were, what should you be aiming for as the absolute things you have to have, and what are the things that would be really, really good to have and really make a place more accessible? So those things we don't resolve in the report, but we lay out hopefully what some of the questions are there. As I said, prioritisation was a real issue. So there was strong support for provision, but especially amongst people who were budget holders or responsible for allocating resources, the question then became, if this, then what can't you fund? Or how do you get the additional funding in to make sure that you can provide the facility as well as providing all the other services? So that then becomes a question of, well, who's responsible for that funding? What do you do in the face of continuing budget cuts to achieve that? What does that mean in terms of the model and the scale that you want to go for? And how do you ascertain what the actual costs of that are going to be? We know that the Glasgow facility is relatively expensive because of the nature of the service that's been set up there. If you go for a less formalised service, what will the costs look like? And look into organisations that might want to deliver that to estimate what those costs are, because that's going to be really important going forward. Like people are going to we couldn't say with any confidence at all really what the costs are going to be, and it's going to be really, really important that someone somewhere on the line gets a handle on that, so they can then say, well, this is how much we can afford, or this is what we need to go away and ask for. So I think that's going to be important to get that input where possible. There's implications for evaluation. Evaluation is going to be tricky, right? So the Glasgow facility is going to be evaluated. That was part of the Lord Advocate's significant element of the Lord Advocate's statement of prosecution policy was the Glasgow facility has to be evaluated. I think one of the opportunities that would come out of having a service in Edinburgh is to ensure that what the Glasgow service is found to be good at and less good at seems what all facilities are good at and less good at, that there are alternative options and models being evaluated simultaneously, so that would be certainly an advantage. But there are kind of questions around, so, you know, what is it that matters most and what scale? So are you looking at just numbers of overdoses intervened and reversed, or are you looking at levels of access to wider treatment support? Are you just looking more qualitatively at how people feel about the community that they feel is being developed around these services? Are you looking at needle litter and those kind of issues? Geographical areas impact is difficult. So, as we say, when you've got dispersed patterns of consumption and harm, how do you assess that? The cost-benefit analysis was really tricky for this report. It was difficult. There is a cost-benefit literature out there around safer drug consumption facilities, but it's quite hard to translate it directly. A lot of it is from from Canada, most of the research is from a small number of facilities. There's a lot of work still to be done, I think, in terms of determining how you would measure those costs in a facility in Scotland and in Edinburgh, particularly in this case. Wider social trends and how to isolate impact. You know, if we're looking at very rapid changes in patterns of consumption, it's then going to be quite hard to say, well, this impacted on. What's your kind of baseline going to actually tell you if the patterns are changing quite quickly? That's a bit of a challenge. And then public perceptions is of course would be difficult as well. So that's something we need to think about. So what do we recommend in the end? So I don't want to go through this, it'd be very tedious, but we recommended as a primary recommendation that this is continued engagement with potential service users, people with lived and living experience that has to be driven, for all the reasons that has been talked about already this morning, has to be driven by that. The need for community consultation, you have to be engaged with communities involved, you have to get a sense of what their aspirations and anxieties are. So we were very keen to make sure that happened. Consultation with existing homelessness and drug services in hotspot areas to talk about possibilities of embedded provision. Protocols to share relevant data. One of the things we've been finding from this is there's a lot of data out there, but collating it can be quite tricky. It can be very tricky at times, so great to make that easier. Extensive levels of trained peer delivery in terms of service design, thinking about a range of different patterns of consumption, informality, but also thinking about safety and security and safeguarding, importance of co-production. So we had various things there. And then some kind of just important stuff that actually is being followed up as far as I'm aware. So there's going to be a need to get some bespoke legal advice. The Lord Advocate's statement of prosecution policy was about Glasgow. It was about the Glasgow facility, and it was absolutely saying, if you do it this way, then this statement applies. But it doesn't. It's not a green light just to open stuff up everywhere else. That would need a separate statement from the Lord Advocate. So there needs to be work around that. And that it's a chicken and the egg thing. Like, what's the sequencing? That needs to reflect the design. So you need to be thinking about the design before you go in, but you also need to be in a preliminary way getting the ball rolling, because these things can take time. So we were very keen to say you've got to get some early engagement with local police, early engagement with the Crown Office and others. Initiating discussions with local and national government on the potential financial angle. And that is what the council's now instructed ADP to go back and do, is to speak to national government as well. If it's a commitment on the part of national government to support this, then there may just have to be some investment centrally for it, but we don't know at all where that stands at the moment. And liaise obviously with potential providers to explore costs of those different kinds of provision. So the recommendations were not absolutely concrete, because you're just not in a position to say this is exactly what it needs to look like, this is exactly where it needs to be. But we were in a position to say there's a case for provision, and these are the steps you need to take to try and make sure that if you do it, it'll be the best version of provision that we can expect. So then, just to kind of sum up, I suppose the things that came out of it overall were, as I say, there was a lot of support, but it was actually, I think, ultimately a question about where a facility fitted within the wider response network and system. People wanted to know what those relationships were. I think the thing about safer drug consumption facilities, and this, it's a kind of a super served issue actually in some ways, I think, in the media. And I understand why that's the case. Again, having been on the advocacy side, you make the case and you go on about it and you talk about it as like, and then everyone says, well, it's not a silver bullet. So I didn't say it was a silver bullet. And people can, I think, quite justifiably say, but you kind of did in a way. I think that's because that's a consequence of the fact that people have to really struggle to get these facilities over the line. I get why that's the case. But I think now actually we're in a position where it needs to be much more not cautious, but I suppose cautious maybe, much more kind of aware of the fact that we're talking about an intervention in the system, one intervention in a complex system, and be thinking about what those relationships are between this intervention and the other parts of the system, how the connections that need to be strengthened can be strengthened, how the connections that don't exist can be put in place. All of that stuff, I think, is the way to think about it. And I think that's probably the way we want to talk about it as well from now on, if possible, is to talk about safer consumption facilities as an intervention in a system and as part of a bigger system. I think we're at a stage where we can start doing that. I think that will help with the advocacy side. I think that will also just help with making sure that if they are introduced, they're introduced in a way that is more effective and in a way that will work well.